So our focus will be on the management of pulmonary embolism. Okay, and then to understand this, you need to remember what we said about the Beckhoff's triad. And we said that for a thrombus to form, you need some things to happen. Okay, so the Beckhoff's triad, we are looking at stasis, which means that, situations that will put you in some form of immobile state and cause blood to stay at one place for a very long time. That's one. We are looking at endothelial damage or endothelial dysfunction. And then we are also looking at hypercoagulable state. Usually amongst the three, it's only hypercoagulable state that, in itself or can single-handedly lead to formation of a thrombus. If you just have stasis without endothelial dysfunction or hypercoagulable state, most of the time it's not likely for you to develop a blood clot. And the same goes for endothelial dysfunction. If you have some form of endothelial dysfunction without stasis or hypercoagulable state, it's not so common for you to form a clot. However, hypercoagulable state alone in itself can predispose you to forming a blood clot. So it tells you that usually in terms of stasis, you should have stasis plus either a hypercoagulable state or endothelial dysfunction, or even sometimes both. And for endothelial dysfunction, it tells you that you should have stasis plus a hypercoagulable state. Usually that's the concept. Once you understand the Beckhoff's triad, then you know how a thrombus comes about. And embolus basically refers to a thrombus that is point that gets dislodged and then moves in circulation. Usually in medicine, we tend to be worried if a thrombus dislodges and finds its way in the lungs, okay, or even a thrombus actually forms in the lungs, okay. So once you have a thrombus finding its way there, then we say that the patient has pulmonary embolism, and it's a case of a dire emergency that needs rapid sorting out, otherwise you lose your patient, okay. Most of the time, or in some cases, should I say, patients who would present with pulmonary embolism would initially be asymptomatic. You might not really know that, okay, this patient has something coming. And even when they start showing symptoms, these symptoms that they start showing can be non-specific, meaning that you can attribute that to so many other conditions. Imagine you have a patient coming to you who start complaining of cough and then a severe chest pain. You can say, okay, maybe this is, a pneumonia. Maybe this can even be COVID, right? So they are non-specific. So to make a diagnosis of pulmonary embolism, you need that kind of strong sense of, thinking, all right, okay, this could be a PE. You should have it at the back of your mind. It's always good to consider PE than to say, oh, you don't think this is a PE. If patients should present to you with certain clinical features like difficulty in breathing, some form of cough, with some form of chest pain, and whatnot, you should also consider a PE, especially if the patient's, with time, you realize that the patient's vitals in terms of BPs are crashing, and then there's some form of elevated pulse rate and then respiratory rate. Then it should even point you to that direction more, that, okay, this could actually be a PE, so we need to investigate. When we talk about investigation of PE, you all remember that we said it's good to see the chest to see if there's any problem there. And that's where we go ahead to do a CT scan. But it's not enough to just take a picture of, the lungs. Just say we are going to do a CT scan. We do a CT scan sort of, and we try to paint out the pulmonary, artery basically. So we are doing more of an angiogram. Okay. So we do a CT pulmonary angiogram for the patient. And once we introduce a dye and it gets into the system, and then it draws out the supply system of the lungs, and we can see that, okay, there's some sort of filling defect. At this part, the dye didn't really get there. The dye has gotten to other places, but at this side, the dye didn't really get there. So there's a filling defect at that particular point. Then we can say that, all right, okay, our patient probably has a P. At this point, let me see if I can give you an idea of how a CTPA would usually look like. So once you make that diagnosis of pulmonary embolism, or even if it's a differential diagnosis, or even if you're thinking this is it without your CT scan, you don't need to wait for the CT scan to come before you manage the patients. Once you think about it, you start putting some management protocols in place, and you only stop managing as an embolism once you have definitely ruled out an embolism. Until you rule out an embolism, you don't stop managing. You manage until you are convinced that, okay, this one is not a pulmonary embolism, because we have a CT scan, which is telling, or a CTP, which is telling us that, oh, don't worry, the vessels are fine, there's no embolus, so you can go ahead and look at other things. Okay, so that is how you start the management of pulmonary embolism. You don't wait to get like your images before you can go ahead and say, all right, okay, this is it. No, you don't do that. So can you see my screen, please? This is
Yes.
all right. Great. So usually if you are suspecting a P and you started management and you request for CTP, because basically that's the definitive diagnostic, material. There's something we call ventilation perfusion scanning, which can also be done, or the VQ scanning. But the advantage with the CTP is that if there are any other condition apart from a pulmonary embolism, maybe the patient has a pneumonia or something, a lung collapse or whatnot, your CT scan or CTPA will tell you, whereas condition that might be present. Okay, so that's the advantage that CTPA comes with, and that's what we do in Ghana for our patients who we think have a P. So you can see. All right. Can you hear me, please?
Yes, sir.
Okay, thank you. So you can see that this is a system here. Basically, they've introduced a dye, okay, and the dye has been able to, gone through the blood vessel and whatnot, but there's a part here in the dye which hasn't been filled, basically. Okay, so there's a filling defect. Ideally, we expect that the dye will go through and then it will cover this whole place, and all this place is supposed to take up the dye, and then it should look whitish. But you can see that this part here the dye hasn't got in here. So if the dye hasn't got anything here, if the dye hasn't filled that part, what does it tell us? There's a vessel, but then the dye hasn't really filled it. It means there's something there which is preventing the dye from taking the shape of the vessel. Okay, so that is how your CTPA would usually look. So you can, go to Google, you'll find a lot of pictures that will give you indication of a filling defect. You can see that this one, the dye has taken all the way here, but when it gets here, there's a filling defect here. Okay, as you can see, then it tells you that, okay, there's an embolus. With that end the patient's presentation, you can make that diagnosis. So as I said, we had a session on pulmonary embolism. So first part was just some form of revision, sort of. Okay. When you go through your slides, you would find out that I've given you risk factors and then various clinical, presentations if you think your patient has a PE. So clinical features will include an increased respiratory rate, an increased pulse rate. They are breathless when they come. They can be cyanotic. And when you listen to the chest, you realize that they have this, funny sound in the chest. Okay. Your investigations basically are doing a pulmonary angiogram, a CT pulmonary angiogram for your patient. There are other things that you can also do if you don't have your CTPA available at that point, even though we say that's the gold standard. There are other things that you can do. You can do an ECG for your patient where you see classic changes, what we'll call the Magen-White sign on the ECG. You can do a chest X-ray sometimes. If you're lucky, you are going to actually find the area of infarct on the chest X-ray. Remember, we said that troponin to go up when you're thinking of an MI in pulmonary embolism, because once you have an embolus or you have something plugging the pulmonary artery, the heart is actually going to try very hard to push blood from the right side to the pulmonary, lead to some sort of damage to some part of the myocardium, which is going to release troponins into circulation. So pulmonary embolism can also lead to troponins increasing. Basically, the reason being that the clot sitting in the pulmonary artery puts a strain on the right side of the heart when the right side tries to push through the pulmonary artery. Okay. You can also do a D-dimer. So there's a classic Magen-White sign where you have a distinct, remember, QRS complex. And if you remember the normal ECGs I show you, the QRS, the S is always sort of in line with this, the Q part. But here you can see a distinct S wave, so you can, instead of having a Q, R, and S here, like the classic peak that we see, it's more of QR, and then the S comes all the way down. So it's a distinct S wave. As you can see, you find that in lead 1, right? So there's a large S wave in lead 1. And then the Q, which is supposed to also be starting on the same line, you can see that here too, there's a distinct Q wave in lead 3. So Q, R, and then the S is normal here. Okay, so a large S wave in lead 1, a Q wave in lead 3, and then an inverted T wave. If you remember the T wave, the normal ECG I showed you the other time, after you have your P wave, your QRS complex, there's the ST segment, and then there's a small mountain here, and we say that's the T wave. Okay, in ECG, you would find that the T wave is basically inverted. it looks like a depression. So you find that, okay. And don't get confused. You can take this and then look at the normal ECG and the schematic ECG diagrams that I gave you in your myocardial infarction lecture. And then you can see the usual, the P wave, the QRS complex, and then the usual T wave small that comes here. But when you are looking at MI, as I said, a big S wave in lead 1, you come to lead 3, and then you find a classic or a big Q wave, so distinct Q wave, and then a T wave, which is supposed to be looking like this, tends to be what's inverted. And that's what is usually known as the S1 Q3 T3 sign. Okay, the S1 Q3 T3 sign. You would see it in some of your MCQs. Okay, so when you see it, it's called the Magen-White sign, S1 Q3 T. That's the lead 1, there's a big S wave. Lead 3, there's a big Q wave, and then this same lead 3, the T wave is inverted. Okay. So sometimes once you see this, and then you see the patient having, the other signs of respiratory distress, pulse rates going up, BP dropping, even before your CTPA comes, you know that likely this patient has a PE. Once you make that diagnosis, you are thinking of, getting rid of the clots. So your management, basically, you are looking at the basis of emergency medicine, which is resuscitation, so airway, breathing, circulation for the patient, for starters. Okay, so you're going to assess the patient's airway, because clearly this patient's saturation is going to drop. So you need to give some form of oxygen as a form of managing the airway. So before giving your oxygen, you need to check the airway to see that the airway indeed is patent and, air can get in there. Okay, so you assess the airway, you start your oxygen, and then you give your oxygen, you give the flow according to what the patient needs. You keep on increasing until you have at least your SpO2 gets to about 96 thereabout for the patient, okay? And whilst you increase, you change your flow devices to make sure you put in there, right? If you realize that your nasal prongs or simple face mask or your non-rebreather mask isn't doing enough, you need to inform your ICU people, because this patient is possible that will need to be moved to ICU for possibly continuous positive airway pressure, which is called CPAP, or even they might have to put the patient on a mechanical ventilator if it's that bad. And then you need to get rid of the clot. So you give medication that would break down the clot, and that is where our thrombolysis comes in. Okay. Take therapy. Usually, when you are looking at your pulmonary embolism, in terms of thrombolytic therapy, you can start your retiplase, the interplase, or altiplase. If you're looking at giving your altiplase, which is usually common, you can give, and the dosing is a bit easier. You give a patient 100 milligrams IV, okay, over 2 hours, right? So you give, once you start your 100 milligram IV, you infuse over 2 hours. And then once you are about finishing your altiplase infusion, or you are almost done with your altiplase, you start your patients on anticoagulation, okay? And in this case, anticoagulation, we are looking at giving our patients low molecular weight heparin, as we usually do. Sometimes you might have to give the patient unfractionated heparin, and with that one, we need to take certain things into consideration in terms of your thrombolysis. so that the patient doesn't bleed too much. But if you are going for a low molecular weight heparins like your NOS, dalteparin example fragment, once you're done with your thrombolytic therapy, you start that and put the patient on that. And at the same time, you are looking at switching the patient, to oral therapy with time. And our oral therapy, if you are looking at the warfarins, it would take about 3 to 5 days to start working. So once you are thinking of converting to oral therapy, you need to start early whilst the patient is still on the low molecular weight heparins. And then during that time where you start, you give yourself a couple of days. And when you are weaning your patient off the low molecular weight heparins, your warfarin by then would have hit its peak and would be working for the patient. So basically, management, you're looking at resuscitating, so airway, breathing, circulation. Breathing is very important. You look at the respiratory rate and you control it. Circulation, you might need to try and give something, because in this case, we said that the BP can fall. So you might need to carefully give or hydrate your patients while also you listen to the chest to make sure your patient's chest isn't flooding. And then your drug therapy, you are looking at a thrombolytic therapy followed by anticoagulant or anticoagulation therapy. Okay, so basically that's what you do for your patient. Once you discharge your patient would have to continue anticoagulation for more than 3 months. And in this case, they can either be taking the oral anticoagulants, which example you have the warfarin, or the new oral anticoagulants which affect clotting factor 10, like the rivaroxaban, or the other name is Xarelto, which is common. Of course, there are other ones like dabigatran and whatnot on the market, but Xarelto or rivaroxaban is common, so you can put your patient on that. Okay. In very, very severe cases where the embolus is so large and has gotten stuck in circulation, that this one you might need some cardiothoracic surgeon specialist to come in and do an embolectomy. It's allowed to call the surgeon to come in and perform an embolectomy. Okay. Also, as a form of prevention to pulmonary embolism, if a patient has a DVT and you are worried about the clots basically, moving from the deep veins into the lungs, you can put a filter in there. You put a filter there, and basically the filter, as the name suggests, will prevent an embolus that has been thrown in circulation from going beyond the filter and getting into the lungs. Okay, so your vena cava filters can also help the patient a lot. Because before the whole embolus will get into the lung, it has to traverse the length of the vena cava and get to the right side of the heart, and then be pushed into the pulmonary circulation or pulmonary artery. So a vena cava filter would basically help restrict this clot from going all the way up as you manage a TED stocking as well. Okay. We've done this more than twice. Twice already. This might be the 3rd time we're doing this. If you have any question, we can take it. But P's are very common, and I expect that in your life as clinicians, you should always have a strong index of suspicion when a patient comes to you, breathless, increased respiratory rate, increased pulse rate, and BP dropping. If you're thinking about your acute left ventricular failure, also think about a possible pulmonary embolism. If they bring a patient to you and tell you the patient was fine and he just collapsed, okay, if you are thinking about a possible start of a CVA, you should also be thinking that possibly this patient has had a P, because some patients will also have a sudden collapse. They will just be there and tell you they can't breathe, and then they just have a sudden collapse. So you should consider P in your diagnosis. Okay, most of the time. So I'll take questions and then we will quickly touch on our next topic. Any questions, please?
Hello, sir. Good evening.
Yes, good evening.
Yeah, please. The thrombolysis and then the anticoagulant.
Yes.
Can you start both at a time, or you have to finish the thrombolysis before?
The thing is that if you have access to thrombolytic therapy, it's better you start that one first. And then afterwards, you start your anticoagulants, because there's a risk of causing massive bleed if you start at the same time. You'd induce some form of bleeding in the patient. So most of the time, we don't want you to, start at the same time. Even if you are given in P, after you let's say you have access to thrombolytic therapy, and you also have access to unfractionated heparin, which is the best form of heparin to give when a patient has an acute embolus. Okay, it's better you give unfractionated heparin, because one, unfractionated heparin has a shorter half-life. Okay, so you are able to control it more. There's a risk of bleeding when you are giving anticoagulants. Low molecular weight heparins usually have a longer half-life. They are relatively safer, but they have a longer half-life. But in a case where a patient starts bleeding, controlling it becomes very difficult because of the long half-life. That's one. Okay, and because unfractionated heparin has a shorter half-life, you can always adjust your dose easily if you have a patient who has a P, and then you are checking your INR during your management and what's not, or your APTT during your management. If you are giving heparin, so you are checking your activated partial thromboplastin time, and your dose of the heparin you are giving is not doing it. It's not really, controlling it or what's not. Having access to unfractionated heparin, you can always control the dose because it has a shorter half-life. In case you are managing a patient like this who you've already given a tissue plasminogen activator, maybe an altiplase for thrombolysis, usually you have to forego the loading dose of the unfractionated heparin. Usually we tend to give a loading dose of about 80 international units per kg. So you have to forego the loading dose and then just do a maintenance dose of a start of 18 international units. So that tells you that if you are doing the two at the same time, there is a risk of causing the patient to bleed massively. Okay, so if you have the two, you start with your thrombolytic therapy, and then if you are looking at giving unfractionated heparin, which is basically the standard, okay, to control it, you would have to forego the loading dose of that 18 international units. You have to forego that loading dose, okay? However, if you don't have thrombolytic therapy, then you have to give a loading dose of unfractionated heparin and then afterwards continue with the maintenance dose. So you don't give the two together.
All right. Thank you, sir.
You're welcome.
Hello, sir.
Yes, hi.
Please, if you have a patient who is a known asthmatic, and the patient comes in to tell you that I'm having breathlessness, and then as part of the history taking, you realize that patient had accidents 3 months ago. So what will prompt you to think about P, since you know that the person is a known asthmatic?
Oh, it's about listening to the chest. If a patient with asthma has breathlessness and comes to you and you are listening to the chest, the sound you hear would be basically different from a patient who has a PE coming to you. One classic thing about asthma is ronchi. As I always tell you, when you are called to go and see a patient who has difficulty in breathing, when you go and you just take a look at the vitals, the next thing you should do, it's good to go through a process: inspection, palpation, percussion, and auscultation, right? So when you go and then they tell you your vitals, you are looking at the patient, you are basically inspecting how the patient is breathing to confirm that there are signs of respiratory distress, like flaring of the A-line nasi, internal, intercostal recession, subcostal recession. You are seeing all that on your inspection. Okay. Ideally, you have to go ahead and then, palpate the patient's chest and then percuss and then listen, right? But in the emergency setting, sometimes you would have to inspect and then listen quickly, especially if your patient is breathless. You want to know what is happening there. Listening, something you should do, and then quickly you can intervene. For instance, if a patient comes to you and a patient has pulmonary edema and there's a lot of water in the patient's chest, okay, and you don't have the time to go and palpate, percuss before you auscultate, especially if the patient is breathless. Once you inspect the patient and you can see how breathless the patient is, it doesn't hurt to put on your stethoscope and then put it at the back of the patient and listen to the patient's chest. Then you hear a lot of crepitations in the chest. And these crepitations are fine crepitations. It looks like a patient has a pulmonary edema. Let me go ahead and then give the patient Lasix. So listening helps a lot. The same way, once they call you asthmatic patient has had an RTA, of course, you're thinking that, okay, this could be a PE, or patient has had an operation not so long ago. Maybe patient has had a CS like 4 weeks ago. Patient is asthmatic and they brought the patient to you. I like the question. It's good you consider, okay, even though the patient is asthmatic, this patient, per the history, they said has had some CS or some form of surgery, abdominal or pelvic surgery, orthopedic surgery about a month ago, which is a risk factor for pulmonary embolism. Even after that month, it's a risk factor for pulmonary embolism. Or patient has some form of cancer, which is also a risk factor of pulmonary embolism. So how would I know this is asthma or PE? Okay. The history might not be so clear. At that time, patient might be breathless, so you can't go and stress patient and be asking for history. You look at vitals and then you put your stethoscopes there and then you listen to the chest. If it's asthma, you hear the classic Ronkai sound. You hear it. You won't hear this when you are dealing with the PE. You won't. So that would help you and it would differentiate it from, asthma for you. You would differentiate your asthma from the PE. Listening would help you. Are you okay?
Yes, sir.
Yeah.
I'm okay.
So yeah, try and go through the slides. I don't know if I did a presentation on venous thromboembolism in obstetrics and gynecology. I did a presentation for the University of Ghana Medical Center. I don't know if I sent you the slides.
No.
As a class. Okay.
No.
All right.
No.
Okay, I'll send you the slides. Just find time and go through. I don't think we didn't say you have PE in your exam, right? But it will help you. Even though it says venous thromboembolism in obstetrics and then one in gynecology, basically the management is sort of similar to what we do in internal medicine. The only difference is that there are quite a number of risk factors in obstetrics and gynecology that we tend to ignore, and those slides will tell you. But when it comes to the management, you realize that it's quite, similar. So I'll send it to you probably later today. And if you are going to sleep, just go through the slides. It's a lot, but go through and then it's simplified. You would understand and you know how, if you decide to give your patient unfractionated heparin, how do we monitor the unfractionated heparin? It's in the slide. If you are giving low molecular weight heparin, you can check your anti-factor 10 levels. It's in the slides. If you are giving the patient warfarin, how do you monitor INR? It's there in the slide. Okay, it's quite detailed, but it's simple. So it will give you some knowledge there. You become venous thromboembolism expert after reading the slides, I assure you. So let's quickly touch on COVID, which is also one topic that I expect that you still have the slides, so you should go through. I remember I said I'll give you a question on COVID.
Yeah.
You were supposed to have a question on COVID either
So
last
is it the internal
semester.
medicine or the emergency medicine?
Oh, I don't remember, but I said it. And when I said it, I even told you that I told you where it will come. So just listen to the audio. Maybe if I say something now, I might contradict myself, but you get a question. You get a question on COVID, and it's supposed to be in your previous audio where it's going to come.
So you said internal medicine. I wrote it
You
down.
said internal medicine.
I said internal medicine.
Yeah, yes.
Yes.
Just be smart about it. You go to.
Yeah, wait.
Okay.
Okay.
Honestly, I don't remember, but I know you get a question there. There's nice question there for you. So get it.
Yeah, it was internal medicine class that you said that, so I think it should be in internal medicine.
Should be internal.
Look, you said nice question. Nice is relative.
Medicine, but,
Okay.
but you see it somewhere. Don't worry. So. So for COVID, I mean, you are COVID expert. So, I mean, you have the slides too. Now, wherever you open, you see COVID. I'm sure more of you even know more about COVID than I do. But of course, you should, once we talk about COVID, you should have an idea of the pathophysiology and you should have an idea of the clinical features, because that is what would point you to a diagnosis of COVID. Of course, if you see a case study where, I mean, we are telling you about patients losing the sense of smell and all that, you should be able to identify that, all right, okay, this is COVID we are talking about here. If you I'm trying to look for something. So if you see a question, you're talking about a patient being breathless and whatnot, and then you're thinking, okay, patient is breathless, so this could be a P. Wow, okay. Now I'm confused. Maybe if I write a P and then the answer is COVID, it's very wide, so I don't get it. You take your time and read into details. No examiner will tell you that patient has lost the sense of smell or patient has anosmia and come and tell you that because I said it's breathlessness, so it's P. No. We all know that in this modern era, if you have breathlessness with some febrile symptoms with anosmia, it's more likely you have COVID-19. So, of course, once you look at clinical features, it should tell you what you're dealing with, especially if we tell you that a patient has anosmia and ageusia, meaning a patient's sense of the taste is also gone, then at least it should point to a certain direction. Okay, all right. Yeah, I think I said internal medicine because I can't find it anywhere in the emergency medicine.
Confirmed.
Internal medicine. So, can you see my screen, please? My screen has disappeared.
Not yet. Empty.
Okay. Yes, so with COVID, I need you to have all the knowledge that comes with it, that you can get access to. But what is having all the knowledge when you can't manage a patient that has been brought to you in the emergency setting? You should be able to manage this patient. Okay. So after knowing that, usually once you get a question like that and you tell me, what if I ask you what's the diagnosis and you tell me COVID, then maybe you're putting me in some. If you tell me it's COVID-19, I'm happy. I know that you know. Okay. And then if I tell you that what is the etiological organism or what organism causes the disease, you should be able to tell me that, it's a SARS-CoV-2. If but I should ask you about investigations. You should be able to tell me investigations. Okay. I don't think I'll stress you with pathophysiology of COVID if I should ask you a question on COVID. But investigations, I expect that if I ask you, you should be able to tell me which one is like the diagnostic investigation for COVID. And then on top of that, which ones are the supportive investigations for COVID. I've taught you, so you should be able to tell me. Usually when you do a chest, a CT scan or an imaging for COVID, we assess it with what we call the COVID-19 reporting and data systems, which is the CORAT, and it's good you know this, okay? But of course, I won't worry you with CORAT. I added it to your slides because when you go and you request for your chest CT scans with people with COVID and the reports come, the radiologists will want to prove to you that they know. So they'll put there CORAT 5 or maybe CORAT 4. Okay, it should tell you that, okay, they are telling you that this condition or this CT scan that we did is this level of suspicious of COVID. For instance, if they tell you, oh, this image is CORAT 1, then it means that basically the CT scan or the imaging findings was normal. They tell you it's CORAT 2, then it tells you that, all right, there are abnormalities on the CT scan, but it's not so consistent with what you usually see with COVID. It doesn't mean the patient that doesn't have COVID. Okay, maybe the patient is now having the COVID, or patient has COVID but doesn't have classic imaging features. So they'll tell you the abnormalities, but it's not so consistent with COVID. If it's intermediate, there'll be abnormalities, but then it will be unclear that, okay, well, you're not sure COVID is present. Okay, but if it's CORAT 4, then the abnormalities are suspicious of COVID. And if it's CORAT 5, it's a typical COVID-19 picture we are seeing, ground glass appearance and all those funny, thing that we tend to see with COVID. And if we say CORAT 6, then it means that you've done an image which is suggestive of, typical of COVID-19, so CORAT 5 plus a PCR. So it's like definitive diagnosis for COVID. Okay. I mean, it adds up to the knowledge, and if you know, it's good, but I'm not sure anyone will bore you with the stages of CORAT. When you have a patient who has COVID, management, as I told you in the past, is dependent on the clinical, stage of the COVID or the category of the COVID, whether you are looking at a patient with a mild case, you are looking at patient with a moderate case, patient with a severe infection or critical infection, right? So I gave you a table that would usually direct you to, what kind of features you're looking out for. As you can see, patients who are asymptomatic, they don't have any clinical features at all. Chest X-ray findings are, fine, but then they've tested positive for COVID. Okay, patients who have mild infection will usually have those, non-specific upper airway symptoms like a cold, constitutional symptoms like a fever, headache, all of those things. When you examine the chest looks fine, okay? If you're looking at moderate infection, then they have signs of pneumonia. So they can have breathlessness, then they can have the wheezing, they can have crackles, all those things, okay? But then they won't have a typical respiratory distress sign where SpO2 is dropping, respiratory rate is going up, but you realize that, okay, there's some form of breathlessness there. In severe infection, they are going to have like severe respiratory symptoms, respiratory depression, and respiratory distress and all that. SpO2 will be below 94%. Okay, and then if you say a critical infection, you've just gone beyond severe infection. Patients. So patient has COVID and at the same time has respiratory failure or has acute respiratory distress syndrome or has shock or has stroke with the COVID, secondary to the COVID, or some myocardial infarction because of the COVID, or acute renal failure because of the COVID. These patients are critically ill patients. Okay, so management clearly will be dependent on what you're looking at. Clearly, we all know that if your patient is asymptomatic, they can, or even mild, they can just be on the usual vitamin C, 1 to 2 grams daily, zinc about 40 mg to 50 mg daily. And we can choose between azithromycin or doxycycline for our patient. Okay, so this is for asymptomatic or mild. In the emergency setting, we are looking at moderate, severe, critical. Okay, and usually we don't admit our patients who have we are asymptomatic or mild. You just tell them to isolate, and then you tell them to get a pulse oximeter, do a regular check of their SpO2, contact you if their SpO2 they think is falling, and then you can make an arrangement, because the fact that someone is asymptomatic doesn't mean he'll stay asymptomatic throughout. The fact that someone is mild doesn't mean he'll stay mild throughout. You can progress through categories, so you need to keep an eye on your patients. Okay, we've had very, very sad stories, and we've seen very sad stories of young people being asymptomatic on day one. The next day they had mild symptoms, and we've had very, very sad stories of people just getting married or just having a baby, and they end up having COVID. They think they are strong, they are fit, and the next week they are gone. So you just have to keep an extra eye on your patient, whether it is asymptomatic or mild COVID. For me, I'm able to achieve that by telling them to get a pulse oximeter, because day in and day out, people will call you, "Oh, Chief, menya COVID or menya them." They will call you, and what would keep you safe and make you innocent, or what would prevent you from feeling guilty if something bad should happen? Because definitely if a patient tells you you don't have symptoms, or you think this is mild, you tell them, okay, go to the hospital, blah blah. Some of them wouldn't want to go, so eventually you tell them, okay, get this medication, get vitamin C, zinc, get azithromycin. We all do that, okay? But then don't forget to tell your patient that get a pulse oximeter, and if you are hypertensive or diabetic, it will be better you go to the hospital for assessments, because they can just change. Or if you're asthmatic, if you have a comorbidity, it can just change. But if not, just get your pulse oximeter and make sure you are doing a regular check of your saturations, and then at least in a day, keep me posted once that, "Oh, Chief, when I check, this is what I got." That alone is enough to save your patient's life. Okay. If you tell your patient that and your patient fails to do that and they fail to go to the hospital and they die, you feel sad for them, but you don't feel guilty. Okay. So for moderate, severe, critical, we need to admit the patient. Usually moderate patients will go to the high dependency unit. You don't admit them on a normal ward. The normal ward is for people who are just there recovering, whatnot. And then your severe critical will go to the intensive care unit, right? Of course, it depends on their requirements, because you can have a severe patient go to the intensive care unit and will feel better, and you have to step down to a high dependency unit. Then you put the patient on oxygen when the SpO2 is less than 94%. Usually, as I said, the flow rate you are given, so you can go through nasal prongs, face mask, non-rebreather mask, to CPAP, or even invasive form where you're doing intubation or mechanical ventilation for the patient. Then the next thing is to start antibiotics. We know it's a viral infection, so why are we doing antibiotics? We know that it helps the patient recover faster, because even though it's a viral infection and it's going to cause damage to the endothelium of the lungs, it doesn't stop there. It leads to a secondary bacterial infection, which tends to kill patients faster. So what do? We put them on strong broad spectrum antibiotics. We can either do Rucefin or I prefer Rucefin, because if a patient has the money, why would you allow the patient to just buy a normal ceftriaxone when they can get a branded ceftriaxone, which works better? Put a patient on that for a week. Sometimes we go all the way to about 7 to 10 days. Okay. Sometimes your patients even on that wouldn't feel better, so you need to 2 weeks they are on strong antibiotics just to get temperature well controlled. Or you can step up and do Meronin 1 gram 8 hourly for the patient. Then, because it's an inflammatory dexamethasone for the patients, we usually start with 12 milligrams start, and then we do 6 milligrams daily, which can be extended. The risk factor for DEXA here is because it's a steroid, and we know what steroids do to blood sugar. It's able to push your patient's blood sugar up. So if you're dealing with a patient who is diabetic, or your patient who basically doesn't have full-blown diabetes, right? It's in the patient you think has an impaired glucose tolerance or whatever. If they get COVID, the infection itself can trigger stress hormones to push sugar up. And on top of that, you going ahead to give the dexamethasone can even make sugar control very difficult for the patient. So we always need to check. And that's why I said that if a patient is diabetic, they need to check their sugar regularly, because the stress of COVID can cause them to develop even a DKA if not managed properly. Okay, remember DKA can happen due to stress of intercurrent illness in your previous lecture. So you give steroids, and because you're giving the steroid also comes with a risk of gastric erosion, so gastritis. So you put your patient on a proton pump inhibitor like omeprazole, esomeprazole. I like brands, so I go ahead and I give my patients Nexium. Okay, as far as your patient is on the steroid, you need to extend your proton pump inhibitors. Then we all know that the pathophysiology of COVID has something to do with thrombi or microemboli and whatnot, if you really follow the pathophysiology of COVID well. And even with a patient going to be in bedridden, you need to anticoagulate the patient. And we know that most patients who die from COVID end up developing a pulmonary embolism, most of them. Okay, if you follow pathology report, you would see. And the disease itself pushes you to a thrombotic state or hypercoagulable state. And with that dysfunction there, you can actually end up forming a clot, which the patient can develop a PE as well. So you put them on anticoagulation. Usually you tend to do a prophylactic dose. Depending on the weight, you do 40 to 80 milligram. We do 80 for people who are big, 40 people not so big. But if you feel that, all right, there's some embolus there, you go ahead and then you give a therapeutic dose to your patient. Usually that's like the basic things we do for them. We know that they do well on monoclonal antibodies, even though they are very expensive, like tocilizumab. So at the peak of the COVID, I had the opportunity to work at one of the first COVID centers, the Industrial Ghana Medical Center. They moved me from my ops and gynae department, and then they took me there. So I learned quite a lot. And then when they opened the Ghana Infectious Disease Center too, they transferred me there for 3 to 4 months to go and help out. So we had cases where we had to use this tocilizumab, and because you tend to have high profile cases coming in and there's money and sometimes health insurance or private companies for rich people, it covers all these things because this tocilizumab is expensive. Last time I checked, it was about 12,000 cedis, okay, per a single dose. So you can imagine. So yeah, you can't have it in the usual setting for every patient who has COVID. Then you'll be killing them in terms of their pockets, because not every patient who has severe COVID will get money. But if they're able to afford tocilizumab, you can give it, and it actually improves, the patient, and they tend to do well. So you discuss with your boss, I think these patients might benefit from tocilizumab, and then you make arrangements, you get it, and you start. There's also remdesivir, which is an antiviral medication, which has been approved. It's been used to manage COVID in so many places, relatively, less expensive as compared to the tocilizumab. So you can go ahead and put the patient on remdesivir as well if the patient isn't doing well. Okay. So basically, That's like the standard management of COVID. It keeps undergoing, they keep evolving management, and if they find something new, they go ahead and they add it. As you know, it's a new disease, and then we keep learning by the day. Of course, once you are managing the patient, you don't stop there. Assuming your patient has critical illness and has an acute kidney injury and COVID at the same time, you need to consider something for the acute kidney injury. So we need to dialyze our patients. How do we get to know patients has an acute kidney injury? And that's why your supportive investigations come in, like a BE and creatinine. If you don't do your supportive investigations regularly, you fail to pick up certain things. So you do maybe BE and creatinine or a liver function test, and then it tells you that creatinine is elevated. Clearly, you need to come in there and then, support the kidney. So you do dialysis for the patient. If your liver function test comes, enzymes, liver enzymes are deranged and whatnot, failure, then you need to come in and support the patient with dextrose and all that, and make sure you're controlling the sugars well. So this is what you need to do. You follow the treatment guidelines. At least every 3 days, you are repeating your inflammatory markers, okay? ESR, C-reactive proteins, D-dimers, serum ferritin. You are repeating them at least every 3 days to know if you are making progress or not, okay? And then you are repeating your LFTs and BE and creatinine to know if the organ system is working well or not. Okay, so that brings me to the summary of COVID management. I'll take questions and then we can just finalize it with a very simple topic. Any questions, please? Or straightforward?
Hello, sir.
Yes, hi.
Let's say, for instance, we have a patient who has been diagnosed with COVID, and at the same time, he's a hypertensive, and you are managing.
Yes.
As part of the I didn't see the antihypertensive.
Yes. Yes.
So why?
So that's why I was saying that you need to add it, and as part of the management. I mean, I didn't put it there because it is not. This is management for COVID-19. But as part of the management, that's why when I was talking about it, I said it's good to monitor things like the sugar. Maybe I didn't talk about BP, but I remember I said that especially your patient with comorbidities, you need to monitor, and then you need to manage their vitals well. So yes, you have to manage the blood pressures, because COVID can also cause your BPs to go up, and you can end up having patient developing a CVA. So during COVID, we make a lot of changes to people's BP medications because their regular BP medications will sometimes realize that it's unable to control the BP. So we tweak it a little bit here and there, change it a little bit here and there, and then patients, they all get towards getting patients' BPs under control. The same thing is what we do for their sugars. So yeah, you need to manage the BPs.
Thank you.
Okay. Yes, please. I think there was another question.
Yeah, so I have a question.
Yes, please.
Okay. I remember you telling us that when you are reading a patient of a steroid,
yes,
you should do it gradually.
Yes.
So how do you do it? Is it good? How do you do it? Like by reducing it in a day or twice in a day, the same dose in 2 days or subsequently, how do you do it?
Okay, that's good. So when you are managing the patient and then you feel that it's time for them to be discharged, that is when you plan on weaning them off the steroid. When you give your start dose of your dexamethasone, initially we're giving methylprednisolone when the whole COVID hits, but research showed that Dexa was also effective, and Dexa is way cheaper. Like you end up spending, it's like you are spending like 5 cedis for dexamethasone and you're spending like 60 something cedis for methylprednisolone. But eventually people got to accept the Dexa, and we're doing the Dexa. So you start you give your start dose and then your daily, 6 mg dose. We're initially doing for a week, but then sometimes you realize that you have to go further. You still do the 6 milligram. When you decide that, okay, it's time to stop the DEXA and you are stopping the DEXA, you are actually going to replace with something else. Okay, you are going to put the patient on prednisolone oral. Do you get it? So it's not like you stop taking, the patient will stop taking the DEXA shots and then that's it. No, you switch the patient to prednisolone, and then it is this time around that we do our gradual step down for them when they are going home per what we know that, okay, maybe starts with 30 milligrams, which is 6 tablets in a day for 2 days, and then come to 20 milligrams, 4 tablets in a day for 2 days, and come to 10 milligrams, 2 tablets in a day, and then come to 5 milligrams. You get it? So that is where we do the gradual step down for the patient. So we just don't stop. We switch them to oral. At the same time, when you switch the PPI to oral. So maybe Nexium 40 milligrams daily for the patient, or 20 milligrams BD for the patient. You switch. Antibiotics, you switch to oral. So I didn't add that because by then you've left the emergence phase and we've even moved, we've stepped you down maybe from the ICU or something. Okay, so you switch all to orals. Your anticoagulation, you can also switch to orals and do rivaroxaban for the patient. So do you get it?
Yes, I do. One more question. So we know the design, the other one, the penicillin are anti-inflammatory.
Yeah.
So why don't you use NSAIDs rather than the steroids?
Like a non-steroidal anti-inflammatory drug.
Yeah. Yes.
Okay. So usually it's a good question, but usually we tend to use NSAIDs with the focus of managing pain or pain management. Okay. That kind of anti-inflammatory effects that you want from you're expecting to get from your steroid itself, your non-steroidal anti-inflammatory drug won't give you that potency of anti-inflammatory effect. Mind you, COVID is systemic and causes systemic inflammation. Your NSAIDs that you take would usually help with your local inflammation. Maybe you've hit your leg or something. It is potent with local inflammation, but in COVID, we are looking at a systemic inflammation, not just inflammation of the lungs. Do you get it? Do you get the concept?
Yes.
Yeah, exactly. Yes. So because of that kind of severe inflammation, your NSAIDs won't do much.
Okay.
Yeah, right. Your NSAIDs won't do much. You're welcome.
Sir.
Yes, please.
Please, in your slide, you said we should give a therapeutic dose once there's a thrombus formation.
Yeah.
And I just want to ask, where will you start from? Are you going to start with the thrombolytic or anticoagulation straight?
Okay. Excellent question as well. So if it depends, it basically depends. You can actually manage your pulmonary embolism without thrombolytics, but it's just that the thrombolytics help, they improve the morbidity and then the mortality. Basically, if you have it, it means that the chances of lysing the clots is faster with your thrombolytics. So if you go ahead and then you do your CTPA and then it shows that there's some huge clots sitting there, it will be better you go ahead and you lyse the clots first whilst you anticoagulate. We are not against that at all. Once it's a PE as part of the COVID, we have to go ahead and then. But sometimes you do the CTPA and then results will come and tell you they are microemboli. Means it's tiny, 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 tiny. So what are you going to lyse? In effect, it's already lysed. And that's what COVID will usually, COVID will give you microemboli, small. So most of the time, we don't really go for the thrombolytics. The therapeutic dose of the anticoagulants is enough to cause, basically, to improve the anticoagulation. Do you get it? Because when you're looking at COVID, you tend to get tiny bits, as opposed to patient has COVID and on top of that has developed a massive emboli, which I saw some last year. And, you know, sometimes in medicine, we as clinicians, we always tell our patients that, oh, don't give up, don't lose hope. But sometimes deep down, we are actually scared for our patients. I'm sure it's happening to all of us. Sometimes you know that, Charlie, this one, dear, if the patient, like, you know, but then that's what you know, tells us that medicine is beautiful and there's science, okay, but there's something beyond science. There's something that's we always have to sleep and wake up and then pray and then thank God, because if you are looking at just science, some things might not make sense to you. So there was this patient. The patient was obese. The patient was about 170 kg. Like, patient is big, short, stubby, short neck. You know, I remember I referred the patients from one private facility from Tishi to us at UGMC. I mean, after managing that patient, I remember they called me at the private facility. I even got some locum to and the patient basically was alive at the end. And it's just God. When they refer the patient, they have done a CTPA. And the CTPA, remember what I showed you, the occlusion and then the filling defect. The embolus had covered over 70% of the pulmonary artery. Okay. The embolus had covered, so there's just a very small space left. And you know, it's not just one pulmonary artery. You know, the pulmonary artery goes and it bifurcates. Okay. The embolus had covered both. There was bilateral block of the pulmonary arteries. Okay, it was just sitting there in the middle. And they referred because they thought the patient was going to die, basically. And even when we got the case, you know, we're like, wow, this is something else. And through some divine intervention, this patient even recovered faster than than most people who we thought, oh, this one will just go home. This one will just, patients recovered faster within that 10 days of coming to the hospital. We repeated the CTPA. There was still some form of P there, but basically patient was now breathing fine and whatnot. And in this case, if we decided to use thrombolytics, it would have been allowed because patients had the COVID and also had the very huge, you know, saddle embolus. So thrombolytics would have been allowed, but we didn't. We just did a high dose anticoagulation therapeutic range, and then we were successful. Okay, so if you have it, if you have your thrombolytics and there's a giant embolus sitting there, you go ahead and give. But your usual embolus that will form secondary to COVID, the microemboli is that tiny that your anticoagulation is basically enough to sort you out. Okay.
Okay, sir. Thank you, sir.
You're welcome. So let's look at the last bit. And the last bit you are actually going to teach me. I just want to see if you remember every or anything we said about that, and also if I want to see how you manage your cases when those of you who have started doing locums. Okay, let's see. This will make it easier. Okay. Can you see my slide, please? A Word document.
Yes, please.
Yes, please.
Yes, sir.
All right. So let's look at the question 3. So a 20-year-old student presented to the ER around 11 p.m. with a history of cough, episodic breathlessness, and a wheeze. So patient says he has had 2 previous episodes of, the above clinical features in the last 6 months.
Sir, please, the
Sir.
questions are not showing.
Oh, they are not showing.
You can see only
So
on
we are seeing 45 and 46.
Yes, it's only the
What you are
NPPs
reading is not showing.
that is showing.
Oh, just a minute. Please, can you see now?
Yes.
Yeah, okay. Okay, so someone should just read the question 3 so that I'll be sure you can see.
A 20-year-old student presented to the ER around 11 p.m. with a history of cough, episodic breathlessness, and a wheeze. He has had 2 previous episodes of the above in the last 6 months. He also complains of tightness in the chest, feverishness, and a runny nose. He usually walks his dog at late hours. He doesn't smoke cigarettes or shisha. Vitals, BP 148/92, pulse rate 118 beats per minute, respiratory rate 32 cycles per minute, SpO2 92%, temperature 37.8 degrees Celsius.
Okay,
A, what
good.
is your most likely diagnosis?
Okay, so this is to the class.
Yes.
I mean, you've seen the question. Let's just imagine you've gone for some locum at night and they wake you up and they give you this case. And then you see it.
Bronchial asthma.
This is bronchial asthma.
Okay,
Yes,
why is it bronchial asthma?
Because of the breathlessness and the wheeze and the tightness in the chest.
Okay.
Yeah.
There is also a hint of the dog walk his dog at the late hours.
Yes, in the night.
Okay, what does that mean? What I mean, walking the dog at late hours.
He is exposed to the cold environment.
The hair from
The hair from the dog can also.
Fair, excellent. So there are 2 risk factors there: the fair and then the cold environments. That's excellent. So those in 400 now had this question for emergency medicine. I think question 3. They had 5 questions. I think I should say almost everybody was able to answer this question well. Just a few people, but was quite straightforward. So it's good. I'm getting positive feedback from you. Okay, so you say bronchial asthma. I agree. What do you think has triggered this bronchial asthma? 1, you're telling me the fair and probably the cold environment. What else?
COVID.
What else in the history can tell you or point to a trigger apart from the fair and then the cold environment?
Smoke. Yes, I can see smoke, cigarette, or.
He doesn't
No,
smoke.
Okay, he doesn't. Okay.
Yeah,
There's infection.
Excellent. Why?
Because temperature
the feverishness and then
that's 7.8.
The running nose
is going up.
Good. So there's some form of infection. So I agree. So there are 3 trigger factors here. So if you're going through the asthma slides I gave you, you would find trigger factors there. 1, allergens like dust, fur, cockroach dander, all those things, chemicals and whatnot. Then cold environment, sometimes even very, very hot environment, and emotional instability. Some people can be too happy and the next moment they have an attack. Some people can be too sad, broken hearts, then they have an attack. Then infections, most of the time, That is what especially with the young people, when they come to you with the attack and you listen to the chest and there's a ronchi, usually whilst you're even auscultating, when you touch them, you realize they are very warm. So clearly that will point to some form of infection. It is up to you, the clinician, to be able to tell us that this infection is an upper respiratory tract infection. So don't worry, once I manage and you're fine, I'm giving you oral antibiotics, you should be okay. Or you should be concerned that, well, maybe this is actually a lower respiratory tract infection, which are usually more severe than upper respiratory tract infection. For instance, if you have a pneumonia, and you'll be more concerned for a patient who has a pneumonia than a patient who just has upper respiratory cough and cold, right? So the fact that the patient has fever, cough, nasal congestion doesn't mean that this is just an upper respiratory infection. You need to listen to the chest to be able to tell that, okay, this is just an upper respiratory tract infection which has precipitated the asthma. Or apart from the ronchi that I can hear from the chest, there are also clinical features suggestive of a pneumonia, which I've taught you in your pneumonia lecture previously. I think pneumonia is also part of what we'll be going through probably on our next session. But you remember features of pneumonia: inspection for respiratory distress, palpation, usually when you touch there's some tenderness, percussion, where you feel that there's the chest is dull, to percussion when there's consolidation, and when there's a complication of the pneumonia like pleural effusion, the chest to be stony dull. Remember all those things that we did. Then you auscultate, and when you auscultate, there'll be bronchial breath sounds, okay, which I taught you. And then I think I even played an audio on YouTube for you. Anyways, so once you've made that diagnosis, okay, this is bronchial asthma, you get 2 marks. Okay, it's fine. So give me 2 differential diagnoses. If it's not asthma, what else can it be?
Bronchitis.
Okay, I can hear bronchitis, I can hear pneumonia, I can hear COVID. Yes, so COVID-19, please. Please put COVID-19. Maybe I might not be in a good mood the day I'll be marking your exam. So if you write COVID, you get 1 instead of 2. So COVID.
Don't worry, you'll be in a good mood. We'll put you in a good mood.
So COVID-19, because it's COVID-19, you see. Otherwise, when the WHO even takes your paper and sees COVID and sees the full mark, don't be happy. Because, no, the WHO won't be happy because they actually came up with this new name recently. And they went for a meeting specifically for the name, and they came out and they said COVID-19. So why are you saying COVID?
You have come to baptize and COVID.
All right, so COVID, bronchitis, bronchiolitis, pneumonia. If you write bronchiectasis, you are correct. It's fine. All right, so I've already mentioned some clinical features, but just to see that you were listening, state 2 clinical features you will look out for during your examination.
Chest pain.
Chest pain. No. I won't accept chest pain.
It's a recession of intercostal recession.
Okay, yeah, so intercostal recession. I'll take that. Wheezing is 1. So let me auscultation. Okay, so I'll take the intercostal recession. I'll take the ronchi. I won't take the wheezing and cough. You know why? It's good you brought this up. When you read the question and you see some features in the question, please don't repeat what is in the question for the examiner. You get it?
Yes.
Okay, sir. Yes, sir.
So there's wheeze and there's cough there.
Okay.
But the thing is that most of the time, if there's some examiners or whoever says the question will want to direct you, most of the time I bring state 2 other clinical features. This time I didn't bring it. but most of the time you see state 2 other clinical features. So then it tells you that don't go and write what's in the question. But even if they don't bring it, because it's just 2, you can go ahead. If they tell you state 10 clinical features, then you list and you're tired, then you can go ahead and put what is in the question. Or you know, it might touch the examiner's heart and they'll give you full marks. But just but once it's just to, you need to basically try and then create something and not just write what is in the question. Okay. All right. So list 4 supportive investigations you perform. So assuming this patient has come, this same case, you definitely have to, you are doing locum somewhere, Charlie. You need to do labs. Private hospital, they've told you even before you started the locum that here, there, you do labs. So if patients come, you need to do labs for the patient. So it's not enough just saying, oh, asthma, let's manage. And then you just start, do this. Okay, you are fine, go home. No. So what investigations will you do for this patient?
Chest X-ray.
Chest X-ray, I agree.
Because full blood count.
Yes, full blood counts because of infection.
Everywhere.
Inflammatory markers, good. Inflammatory markers is good. And what else?
Hey,
Sputum.
Hey.
Yes. Sputum, sputum for either microscopy or for culture and sensitivity. Yes, that's good. What else? So you've said full blood count, you've said chest X-ray, you've said sputum, you've said inflammatory markers. That's good. What else would you want to do?
Lung function.
Lung function test. If you say lung function test, you still get the marks.
Allergy testing.
Yes, you get it. Yes.
So
If you say inflammatory, so
we've already said.
yes, so if you say inflammatory markers, you want to know that is there enough to say inflammatory markers?
I have a question.
Yes, please. Let your question come. Hello. Hi.
I since you ever mentioned about this exercise test or whatever.
Yes, so it's in your slide.
I'm saying that, so if you stay in the yes, hello, sir.
I can hear you. Your network is quite slow, but I know, yes. Hi. You want to know that is it just enough to say inflammatory markers or to put the investigations there? You have to test out. If sometimes, even if you say 4 investigations and you say, hi, hello.
Network. Address the issue. We will tell him later.
Yes. I mean, he wants to know that is it just enough to say inflammatory markers?
So my question was that is it? Exactly.
Okay. Yeah, of course. So you need to sometimes if you say inflammatory, if you write full blood count, you write microscopy for blah blah blah, sputum for microscopy, you write all that and come and write.
Please.
Yes, we can hear you too. If you write full blood count, you write all and then you come and write inflammatory markers, we can go ahead and mark you correct. At the same time, even if the inflammatory markers, you tell us erythrocyte sedimentation rate, C-reactive protein, we'll still mark it separately. It's good to write the that particular inflammatory marker out if you know the name clearly. And I'm sure nobody will just write inflammatory markers. You say inflammatory markers like, okay, so you need to put it out there. Okay. I think there was another question. Okay, so let's go on. Others said BE and creatinine and LFT. I won't accept BE and creatinine and LFT because they are not directly going to impact your diagnosis in any way. For asthma, we don't routinely do a BE and creatinine, and we don't routinely do a liver function test. I accepted allergy test because as part of your management, sometimes you need to know what the patient is allergic to. You don't do it there and then whilst the patient is on admission, but when you are discharging, some of the patients will want to know, so they can go ahead and then do an allergic profile for you. And that's the same reason why we sometimes do an excess for them. And then we can sometimes do what we call a metacolin provocation test for them. Mind you, diagnosing asthma is a case of clinical, judgment or diagnosis. You don't do investigations until you have asthma, like maybe you do an investigation, maybe a head CT scan for a patient and you find an infarct and say, oh, you have an infarctive stroke. In asthma, no, you don't do X-ray and say, oh, you have asthma. You don't wait until investigation to say a patient has asthma. When you listen to the history and you examine the patient and you listen to the chest, it's enough to make a diagnosis of asthma. The investigations we do are basically supportive investigations and are supposed to be diagnostic when we are thinking of something that has precipitated the asthma. So we want to diagnose what it is that has precipitated the asthma. It's not like we want to diagnose the asthma, no. We just want to support the diagnosis of the asthma and we want to pick up or diagnose what has precipitated the asthma. Okay, so basically that's it. And to the main reason for this evening, someone should tell me how to manage asthma and then we can close. It's straightforward.
You nebulize with bronchodilators.
Okay, is this the first thing you want to do for the patient?
No.
Emergency medicine.
You admit.
Resuscitate.
Okay, admit, resuscitate. Good. So
yes.
airway, breathing, circulation.
Yeah.
Good.
Yeah.
And resuscitate.
Okay.
Oxygen therapy.
Okay. And what else? And then what else?
And
then you give your salbutamol.
Yeah, then you nebulize with your bronchodilators.
Okay.
Salbutamol.
Or terbutaline. Yeah. Usually we give salbutamol. Yeah. So tell me how much salbutamol you give. This is asthma. So the reason why the 8 marks is there for most, you see, for most of the diagnosis, I won't stress you if you don't tell me. For instance, if I ask you to manage COVID and then the antibiotic, you say, administer IV urosephin, and you don't put the dose there. I mean, I want, and you state all the, all the investigation, all what you're supposed to give, and you even tell me about tocilizumab or remdesivir, and you don't put those there. And the mark is 6/6. You end up getting the 6/6. I don't mind the doses. With those ones, you look in your STG when you start practicing and they will come. If you are managing stroke and then you want to give your patient some form of, statins or something because it's an infarctive stroke, if you don't write maybe atorvastatin 40 milligrams, I don't mind. Even if you say administer statins, administer antiplatelets, example, aspirin, you get full marks. But if you are telling me about something like asthma, about something like malaria, and you don't tell me those, you won't get full marks. Especially if the marks for the management is a lot, then it means that if you just say administer bronchodilator, example, salbutamol, you won't get the full mark there. If you state all the steps out clearly, you can end up getting 5 or 6/8 because you didn't say administer salbutamol. What's the dose of salbutamol that you give to an adult patient?
5 milligrams.
5 milligrams.
5 milligrams.
5 milligrams.
5 milligrams.
The solution is 5 milligrams.
Okay, so you give 5 milligrams. Okay.
Yes.
When you give the 5 milligrams, what do you do next?
You give your hypertrophy.
Is that what you do next? You just give 5 milligrams salbutamol and then you go ahead and give 0.5 milligrams of ipratropium.
You observe the patient. You can repeat.
We wait for 30 minutes.
Okay.
Yeah. So you observe the patient and repeat it.
Good. So 5 milligrams that you repeat in 30 minutes for 3 doses. So 5 milligram, 30 minutes with 5 milligram, 30 minutes with, and then another what? 5 milligrams. So you are giving 3 cycles of 5 milligrams, 30 minutes apart.
Yes.
Okay. But when your patient comes and then you are assessing ABC, so you set a line. Whilst you are nebulizing the patient, the 5 milligram is going. It might take maybe about 10 minutes. What do you do with the line in situ? What do you do? It's very important.
You can give hydrocortisone.
Yeah, you can give IV hydrocortisone.
You give IV.
Yes. You give your IV hydrocortisone 200 milligrams start. So most of the time, just these 2 things is enough to relieve the patient of the asthmatic attack. Just doing these 2 things is enough. It's enough to quench the asthmatic attack. So nebulize, and whilst you're nebulizing, your line is in there, you've given a start dose of IV hydrocort 200 milligram. You give IV hydrocortisone 200 milligram start, and then the nebulization continues. Once it's done, 30 minutes interval, you nebulize again. Once it's done, 30 minutes interval, you nebulize again. 3 cycles. Okay. After each cycle, you need to listen or auscultate the chest. Try to pick out your own kind. That is what to tell you that, oh, we are making progress, or we've nebulized 1, it's still the same, twice is the same, 3 times is the same. No, we are not making progress. You need to listen to the chest. Sometimes some patients who come and they are very troublesome. They'll rush to the facility, they can't breathe. As soon as they come to you and you start nebulizing, and then you go ahead to give your hydrocorts. As soon as you do that, the attack just stops. And then they'll tell you that after that 1 cycle, they want to leave and they want to go back to work. It puts you in a very difficult situation. You have to let such patients write a note because you haven't completed your 3 cycles. Okay, so that would be like discharge against medical advice. So basically, yeah, you do that for the patient. If after your 3 cycles, you realize that no, this is not really doing the trick, you go ahead and you do the ipratropium as you said.
Okay.
Good. So that's where the ipratropium comes in. You are giving 0.5 milligrams to your patient. Okay. And then sometimes you can do a back-to-back. So as soon as your ipratropium is done, you go ahead and then you give your patient the Ventolin or the salbutamol, and then you come back and then you do your ipratropium. Okay.
Okay, so what about I'm not feeling? When can you also give an I'm not feeling?
Yes, so it's in levels. So now we've given salbutamol, patient is still breathless. Even with our hydrocortisone gone, we still have issues. So we've gone to ipratropium. Patient is still not completely okay. Then you step up to aminophylline. So if you get a question like this, I expect that you bring in aminophylline as you've asked. So when salbutamol or ipratropium bromide is not enough to control the attack, you step up to IV aminophylline, 250 milligrams in 500 mils of normal saline or DNS or 5% dextrose. You give the patients, you are doing that every 6 hourly for 24 hours. Usually after you go through your first stage of ABC, then your salbutamol or hydrocortisone, patient feels better. If not, you add your ipratropium, patient tends to feel better. But if not, then you progress towards aminophylline. Okay. If this fails, then you should be thinking of moving the patient to the ICU to involve the anesthetist and whatnot, because they might have to intervene and then take over the patient's breathing. Okay, are you okay?
Yeah, yes, sir.
Okay, so with your salbutamol, after you've given your first 3 doses 30 minutes apart, if the whole thing didn't just abate, or you were not able to abort the breathlessness, or hello, hi.
I have a question.
All right, okay, please let your question come.
Oh, okay, please. Some facilities, like some health centers, they may not have the nebulizers, nebulizer machines. But
yeah,
this is, so in that situation, can we give the salbutamol orally along with the hydrochloric IV?
Okay. You can do it. It doesn't spoil anything, but that is not the standard of care. That is not what is in your standard treatment guideline. You can go ahead and then give oral salbutamol to the patient. It might give the patient some form of relief. Basically, it's a what? A beta-2 agonist. So once it goes into the bloodstream, it will cause bronchodilation. But you see, we are looking at the time. How soon are we getting the bronchodilation? As soon as you nebulize your patient, you almost get instant results. Rather than the patient having to take the medication, it goes to the stomach, then, has the drug and whatnot. So it is not routine for managing asthmatic attacks. Patients can go on salbutamol tablets when we discharge them and whatnot. But when they have an attack, they have to come in for nebulization. So it is wrong for us not to have this nebulizers in our facility. It's actually a wrong thing. Okay. So I was saying that usually after you give your 3 cycles apart, if you need to admit your patient, you are looking at giving your salbutamol every 4 to 6 hourly. And if you are doing impratropium, you are looking at giving it every 6 to 8 hourly. Okay. So you need to try and then split the doses in such a way that at least every 2 hours you have some medication going. So if you know you are giving your salbutamol every 4 to 6 hourly and ipratropium every 6 to 8 hourly, you don't go and give all at the same time. And then maybe next time you come, the doses will clash. So you try and separate them based on the timing that you are giving. Because if the patient is going to 2 to 3 hours, they are either getting salbutamol or ipratropium. And usually the nurses will help you. They are good at calculating the time on the charts for you. So they have to be your friend so that they can just direct you and then you know what you are giving at what time. And then after you give the hydrocot 200 milligram start, you can go ahead and then do every 6 to 8 hourly, you are giving 100 milligram of the hydrocot. Once the patient, your labs come in, you realize that, okay, there's an infection, like in our case study, people go extra mark for managing infection, not by writing antibiotic, but then they said, based on the symptoms, it's likely there's an infection. So they would go ahead and then manage the infection. That one alone tells me that you've read the case study. Okay, so once you think there's an infection, maybe your full blood count comes and then there's some form of neutrophilia, you give your antibiotics. And usually with lung cases, we are looking at gram-positive and atypicals, which we'll be talking about when we do pneumonia. So gram-positive, we are looking at giving your penicillin, so your amoxicillin. But in this case, we don't do it anymore. So we do amoxicillin plus clavulanic acid, which is amoxiclav or augmentin. And then your atypical, you are doing azithromycin. And that's why we end up giving patients amoxiclav and azithromycin, because they cover the 2 commonest, organism groups that causes infections, whether upper respiratory or lower respiratory. If you are looking at bacteria, okay, of course, more upper respiratory infections are caused by viruses, but viral infections are usually self-limiting. You don't give any antiviral drug. We end up giving antibiotics for upper respiratory tract infection even though we know they are viral, because of risk of secondary bacterial infection, which will delay the recovery of a viral infection. But if it's just about viral infection, you can just do your vitamin C and zinc, take lots of oranges, and then maybe some antipyretic, you should be fine. Okay. But if you are looking at preventing secondary bacterial infection, you add your antibiotics to it. Once you do this, you discharge your patient. Mind you, you gave hydrocort, which is a steroid. Now your patient is going home. Just like what I said about the COVID, you have to put the patient on oral steroids. So you can put a patient on prednisolone, 40 to 60 milligram prednisolone, and then you taper down gradually. Okay. And you always try and calculate, depending on where you are starting from. If you are starting from 60, for instance, you can tell them to do 60 on day 1, 50 on day 2, 40 on day 3. You come down gradually. If you are starting from 40, you come down gradually. Okay. There's no formula to it. Just that you need to taper it down until you get to the lowest dose, which is 5 milligrams. Okay. Then your patient will go off it. And of course, you discharge your patients. If they have Ventolin inhalers, you discharge them on it. But Ventolin inhaler just comes with a beta-2 agonist, which is the salbutamol. Now, there are a combination of inhalers which have beta-2 agonist in them and steroids in them. Okay, like Symbicort and Seretide. You put your patient on Symbicort or Seretide. Okay, because right now they are on the market. So Symbicort contains budesonide and formoterol. Budesonide is a steroid. Formoterol is a beta-2 agonist, which is a long-acting beta-2 agonist. So your patient can just take one puff in the morning, one in the evening, and the patient will be fine. So these are known as preventers because they are long-acting. And then Seretide contains fluticasone, salmeterol. It's in your slides. Fluticasone is a steroid. Salmeterol is a long-acting beta-2 agonist. So this is a preventer. So you put the patient on it. When the patient gets an attack, this Seretide and Symbicort usually takes a long time to work because it's a long-acting drug. It will take a long time to hit for an initial treatment. So when there's an attack, it doesn't really help. When there's an attack, you go back to your traditional salbutamol, your Ventolin inhaler. So those ones are called relievers. So you use your Ventolin inhaler when there's an attack to relieve the attack. But after the attack, if you want to prevent further attacks, then you use your Seretide and your Symbicort because they contain long-acting beta-2 agonist. Okay, so that will bring us to an end of today's lecture. Would have a lecture on either Saturday or Sunday. I'll communicate with Nick. And then in terms of what time you would want to write it. If you want to write it early in the morning, we might have to postpone to Tuesday because we were having printing issues today, so we were unable to print time the day, then we can still write on Monday. But if you want to write early in the morning, then we'll have to write on Tuesday. So you decide as a class and you get back to me. Yes, hi.
Hello, sir. The original date is 31st.
31st is Tuesday.
Oh, the original date is 31st, and not Monday. Eh?
No.
Okay, all right, okay. Okay.
Hello.
Me, I want it fast.
Hello, sir.
Okay, Monday. Yes, hi.
Please,
Hello.
this one is just a suggestion. Looking at the last semester's performance, as you know, it was not really good. So this one, we are pleading if you can give us just few areas so that at least you'll be more concentrating on those ones so that there wouldn't be much failure.
I'm giving you
few areas. The has been given
Really?
I'm giving you few areas, so Chief, I'm giving you areas. So please consult the previous lecture. I'm sure Nick recorded.
You should be careful about me. Okay, sir.
Don't come to class.
And group studies. When I was in school, I didn't really like group study. I usually like to be solo, and then I grab more when I'm solo and I study. That was back then. But then I tried group study once for an exam which I wasn't so prepared for, and it saved me. I realized that when people talk about group study, it works. Okay. And I know sometimes people don't like going for group studies because other people would have learned and they'll come and show off and will demoralize you. There's no shame. In this life, there's no shame in not knowing and accepting that you don't know, so you want to learn. That is the only way to succeed. If you don't know and you accept that you don't know, you want to learn, you pay attention and then you listen to what other people have to say. And that's one of the gems to success, especially when it comes to group study. If you know, you don't have to keep it to yourself. People know, and when they go to group study, they don't talk, they keep quiet, and then they go and take other people's own. Selfishness is difficult. In life, you all have to move together. So if you know, you talk. For you, surprise you that you think you know, and what you say there at the group study, someone will correct you and say, oh, this is it. And it will be better you spoke out. So you can look at doing group study since you have areas to study. At least you can do a group study tomorrow or Sunday, like 2 hours. Not even so, some 2 hours. Even master's students, we do group studies because we realize that it is easier that way and you can cover lots of areas. You can share the topics amongst yourself in smaller groups. Maybe someone will read on COVID. If you have a lot to learn, it works when you have direct areas. Share the topics amongst yourself. Maybe like internal medicine, someone is reading on probably something like CKD or something. Someone is reading. So read, and then you come and share. Or 2 people are reading on that area. They come and then they share. They ask questions, and it will be easier for the others. And whilst they share, you go through the slides. With this, nobody will get less than 65 in the exams. Trust me, if you guys work as a team. But if you work solo, then it becomes a challenge. Okay. And I understand that MCQs are difficult. I understand. Okay. But it depends. If I realize that your rating is good, the reason why I add the MCQs, even though MCQs are difficult, some people good marks in the MCQ, and the theory that we rather get reading areas, they get lower marks. So it will usually not be fair to say that I'm going to skew the MCQs and make the MCQs 30% and make the rating 70%. It might not favor such people. But if everybody is doing well in the rating, I won't mind making that difficult MCQ take only 30 marks and your rating take 70 marks so that everybody can get above 60. You get it. But if I do it that way and people are not doing well in their rating, then it won't be fair, because then some people will do well in MCQs and don't do well in their rating. So I can't really generalize it and say that I'm making their MCQs 30%. So you guys should just put effort into it. You have study areas, form groups, use this strategy, share the topics, and let those who have it come and discuss, and you all go through the slides and possibly just pick one case study on the internet about it. You have the format of my questions. Okay, I'm sure while I was going through even this asthma, you took screenshots, you have formats. I'll ask you about diagnosis. I'll ask you about clinical features. I'll ask you about differential diagnosis, investigations, and management. Sometimes I'll ask you about pathophysiology. That's how I set my questions. And yes, and complication. So you have the format. So just read according to that and you'll be fine.
Complications,
Yes, please.
Sir, please, I just want you to be clear on the date. Is it Monday or is Tuesday?
It's Tuesday.
Yes.
As for the time, you should communicate as a class and get back to me. I'm actually free on
You already gave us 2 o'clock.
Yes,
I gave you 2 p.m.
Yeah, that's what that's the information we got.
All right, okay, then 2 p.m. it is. Okay, so enjoy your evening, and then we'll have a lecture either tomorrow or on Sunday. Okay. Good night.
Okay, sir. Good night.
All right.
Good night.
Okay.